Lumbar spine surgery, an update. Given surgery is often a last attempt option for some of our patients, we should be at least generally aware of the different types available. With new advancements, patients are often sold on the new is better concept and swept into the decision by the enthusiasm of the surgeon who's excited about trying out this new approach. Yet, what is known about new and old procedures is far less than one would expect from a scientifically based profession. Remember the enthusiasm of hip replacements, which actually began in the 1970s with metal-on-metal implants, and the discovery that what scientifically seemed reasonable was not. They were back to the drawing board. Again, resurfacing in the early 2000s, new problems became evident. Eventually, advancements led to the current state of the art. But in the meantime, many patients were in essence guinea pigs, given that many of these procedures never passed the muster of a randomized controlled trial. Here's some important stats. Lumbar discectomy is performed over 480,000 times in the U.S. annually. Hospital costs for complex spine surgeries can reach up to $80,000 per patient. The United States has the highest rate of low back surgery, and these rates have increased by 55% from 1979 to 1990, with now 21 per 100,000 Medicare beneficiaries having a spine surgery annually. Before we review some current research on commonly used back surgeries, let's review the different types and how they're categorized. There are basically two types of spine surgery: decompression and fusion. Both may be utilized together in some procedures. Let's start first with decompression surgery. It's categorized by what is done and how. Decompression may occur through discectomy and laminectomy or otomy, or a combination of the two. The surgical techniques used are divided into two types, open and microscopic. By combining the two categorizations, different spine surgeries are named. For example, microscopic discectomy, microdiscectomy, endoscopic discectomy, and discectomy with and without laminectomy. Here's some common examples. Percutaneous arthroscopic mechanical discectomy. A discoscope is used in either a biportal or single portal approach. Fluoroscopic monitoring is essential. Patients meeting selected criteria have a success rate of 90% if you include increased mobility and reduced medication. However, only 66% in one study had returned to work. Here are two more: percutaneous laser discectomy and percutaneous suction discectomy. Laser ablation disc removal is a questionable technique due to the high cost of laser equipment and the potential for inadvertently injuring adjacent tissues, such as the vertebral end plates or spinal nerves, leading to chronic low back pain. For percutaneous suction discectomy, also called automated percutaneous lumbar discectomy, the nucleus pulposus is removed with a rotary cutting device attached to an aspiration probe. Studies have not shown consistent long-term results, and it's less cost-effective than microdiscectomy. Open limited discectomy, also called microdiscectomy, is considered the treatment of choice by many surgeons. We'll discuss that in a moment. Anterior discectomy and fusion is a combination of decompression and fusion. Anterior surgery is considered unnecessary given the less invasive limited laminotomy and fragment excision techniques just mentioned. So what is microdiscectomy? Well, a 1 to 2 centimeter incision is made over the midline at the level of the herniated disc. Laminotomies are performed as needed to allow visualization. There's a retraction of nerve roots to allow access to the herniated disc. Both sequestrectomy and intraannular discectomy are performed. Patients remain in the hospital for only 1 to 2 days. Now the second type of procedure, fusion surgery. Fusion surgery is categorized by first the anatomical approach, posterior, anterior, or combined into a 360-degree approach. Surgery is further defined by entries such as lateral intertransverse or transforaminal, coupled with the term interbody fusion. The older approach, as mentioned earlier, is the anterior approach. Further differentiation is based on whether it's instrumented or non-instrumented. Instrumented means the addition of screws, hooks, cables, cages, etc., whereas non-instrumented implies that stabilization is primarily through bone, which is divided into autograft, also called autologous or autogenous, meaning from the patient, or allograft, meaning from a donor. One of the most common types of fusion surgeries is minimally invasive transforaminal lumbar interbody fusion, or TLIF. Minimally invasive TLIF has been shown to be superior to the traditional open procedure in terms of postoperative back pain, total blood loss, need for transfusion, time to ambulation, soft tissue injury, and functional recovery. Under fluoroscopy in the anterior, posterior, and lateral views, a spinal needle is used to locate the level of lesion. Unilateral pedicle screws are placed percutaneously over a guide wire, and then a laminectomy and TLIF are performed via 21 mm non-expandable tube. The advantage is the minimally invasive approach, which preserves the midline muscular and ligamentous structures. Patients are usually released within 24 hours following the surgery and are able to return to their daily routines and work within 2 to 3 weeks. Compared to the traditional 4-hour procedure, this surgery takes only 45 to 60 minutes with minimal blood loss. There's also less pain because of the smaller incision. Let's compare this to the older approach. The older open surgeries required larger incisions in the back or abdomen. For anterior approaches, vascular surgeons perform this portion of the surgery, often requiring complicated dissection of muscles, nerves, and even organs, so that the surgeon can gain access to the affected area. This preliminary process can take hours, even before a spine surgeon begins. Patients are at much higher risk for greater blood loss and nerve and muscle injury. Some surgeons still use this approach in select patients. Obviously, one of the largest concerns about lumbar spine surgery, other than cost, is adverse events and complications. Past reviews of complication rates for lumbar spine surgery included 11 studies with an overall mortality rate of less than 1%, but a complication rate of 3.7% to 12.8%. There's also a problem with terminology. Complication and adverse event have significantly different meanings, but are often used interchangeably. When differentiated, an adverse event is defined as any unexpected or undesirable event occurring as a result of spinal surgery, whereas a complication is defined as a disease or disorder, which is a consequence of a surgical procedure. In one prospective observational study, this distinction was used, and the researchers reported an overall adverse event rate of 14% and an overall complication rate of 3.2%. In this study by Street et al., published in the Spine Journal in 2011, the first prospective approach to studying morbidity and mortality for spine surgery was conducted. There were 942 consecutive patients who were followed over a 12-month period. By chance, there were 471 elective admissions and 471 emergencies. A reporting instrument called the Adverse Event Form SAVES version 2 was completed in 100% of patients. 78% of these forms were complete by the time of discharge, with 22% returned later to the attending physician. The results? An overall intraoperative adverse event rate of 12%, and with the previous year, a chart review retrospectively identified an intraoperative rate of 9.8%. The researchers also concluded that postoperative events appear to be grossly underrecorded by traditional methods. The four most common intraoperative adverse events were dural tear, anesthetic-related, blood loss, and hardware malposition requiring revision. The total incidence of intraoperative adverse events for the elective group was 14.6%, compared with 9.3% for the emergency group. The incidence of iatrogenic dural tear in the elective degenerative group was 12%, significantly higher to the incidence in all other groups. The incidence of infection for elective surgery was approximately 3%, similar to a recent previous publication by the Scoliosis Research Society, where they reported on 10,329 patients undergoing surgery for spinal stenosis, with an overall complication rate of 7%, a mortality rate of 0.13%, a 3% dural tear rate, and a 2% infection rate. In this recent publication about the incidence and mortality of thromboembolic events in lumbar spine surgery, we're reminded that when one thinks of spine surgery, it's easy to forget that in addition to local damage, other adverse events, such as infection and vascular accidents, occur. In this study, published in Spine in 2013, the researchers studied the incidence of deep vein thrombosis and pulmonary embolism as complications of lumbar spine surgery. They found an incidence of deep vein thrombosis of 2.4 per 1,000 cases for lumbar decompression surgery and an incidence of 4.3 per 1,000 cases for lumbar fusion. For pulmonary embolism, the incidence for lumbar decompression was 1 out of 1,000 and 2.5 per 1,000 for lumbar fusion. These patients had higher preoperative pulmonary circulation disorders, coagulopathies, fluid electrolyte disorders, anemia, and obesity. Also, the rate was higher for large teaching hospitals. Now let's spend some time reviewing two surgical advances intended to prevent some of the most concerning issues regarding decompression and fusion surgery. These include adjacent level disc degeneration and reherniation requiring the need for another surgery. Let's start with total disc replacement. A review published in 2012 is Total Disc Replacement for Chronic Discogenic Low Back Pain, a Cochrane review by Wilco et al., published in the journal Spine. Why artificial discs? It was believed that they act as a low-friction device allowing more spinal mobility. Articulating surfaces are either metal on polyethylene or metal on metal. Although such devices allow controlled motion, they don't replicate the elasticity of the normal human intervertebral disc. So some questions in need of answers. What is the effectiveness of a disc replacement approach versus spinal fusion or other treatment options? Does disc replacement actually preserve motion at that segment? What's the safety of disc replacement with regard to stability, longevity, adjacent segment degeneration, facet joint degeneration, and preoperative complications? And is there a safe salvage procedure for failures? This review included studies for the following devices: Charity, ProDisc, Maverick, and Flexicor. 7 studies were included. One study compared ProDisc with a rehabilitation protocol with cognitive treatment and physical therapy. 6 studies compared total disc replacement with fusion. The results? The pain improvement for total disc replacement measured using a visual analog scale did not exceed the clinically relevant difference of 15 millimeters and had a low quality of evidence. On the Oswestry Disability Index measure, scores favored disc replacement but also did not exceed the clinically relevant difference of 10 points at only 4.5 points. There is moderate quality evidence that patient satisfaction at 24 months is more common with the total disc replacement group compared to the fusion group with an odds ratio of 1.93. Patient satisfaction for fusion is only 50%. So how did disc arthroplasty compare with rehabilitation? Only one low risk of bias study compared disc replacement with rehabilitation. The average effect for improvement in back pain at 24 months, 12.3 millimeters, is below the clinical relevant difference of 15 millimeters. The researchers concluded that studies reviewed indicated that, quote, between the interventions, the differences on the primary outcome parameters, including their 95% confidence intervals, were small and did not exceed clinical relevance and/or the quality of evidence was low or very low. They state, quote, therefore, because we think that harm and complications may occur years afterwards, the spine surgery community should be prudent about adopting this technology on a large scale, despite the fact that total disc replacement seems to be effective in treating low back pain in selected patients and in the short term is at least equivalent to fusion surgery. Now, a review of the 10-year survival and clinical outcome of the AcroFlex lumbar disc replacement for the treatment of symptomatic disc degeneration, published in the Spine Journal in 2013. The AcroFlex is a total disc replacement device that was discontinued due to mechanical failure detected by fine-cut CT in 35.7% of subjects within 2 years. No further devices were implanted beyond December 2000. So what is the AcroFlex? It consists of 2 titanium end plates bound together by a rubber core. The device allows 6 degrees of freedom segmental motion, with translations and rotations about the 3 independent axes, theoretically reducing stress concentrations. The device is intended to mimic physiological levels of shock absorption and flexibility and stiffness. The original study for the AcroFlex involved 28 patients with symptomatic disc degeneration. 39% underwent a total of 14 revision procedures. 4 of 11 subjects had an instrumented posterolateral fusion without the removal of the implant initially. 2 of these 4 proceeded to the subsequent removal of the implant and conversion to a circumferential fusion. 7 subjects had removal of the AcroFlex and conversion to anterior lumbar interbody fusion supplemented with pedicle screw fixation. Indications for a revision included device failure in 7 and disabling pain in 4 patients. The mean time to revision was 3 years. The AcroFlex was supposed to prevent adjacent level disc degeneration. However, 68% demonstrated an adjacent level disc degeneration with the AcroFlex. Only 40% of those who had been converted to fusion had ALDD. Skip-level disc degeneration was present in 44% of those with the AcroFlex device, but only 20% of those who had been converted to fusion. So what happened to bone? Heterotopic bone formation was evident in 85% of disc levels and regarded as severe, described as equivalent to fusion in 50% of involved levels. Osteolysis was present in 50% of disc levels and regarded as severe, extending across more than 50% of the end plate in 28% of levels. Only 14% of the retained discs showed no evidence of heterotopic bone formation or osteolysis. Here's another study of adjacent level disc degeneration of facet arthropathy after disc prosthesis surgery or rehabilitation in patients with chronic low back pain and degenerative disc disease. This was published in Spine in 2012. Again, disc replacement was developed in part because it was believed that fusion might accelerate adjacent level disc degeneration beyond the natural course of disc degeneration due to stress from increased range of motion in adjacent levels. Past research has determined a 6% annual increase and 34% incidence of ALDD at 22.6 years. In contrast, the annual increase in natural disc degeneration is reported as only 3 to 4%. Here's what's interesting. The reported incidence of symptomatic ALDD after lumbar fusion was 16.5% at 5 years and 36.1% over 10 years. No ALDD developed at 17 years on average after disc prosthesis surgery in patients who had maintained at least 3 degrees of range of motion at the level of surgery. However, ALDD developed in 20% of the patients with less range of motion. So here is the current spine study population. The inclusion criteria are interesting, but what is most noteworthy is that one inclusion criteria is physiotherapy or chiropractic treatment for at least 6 months without sufficient recovery. So we know these patients had the opportunity for conservative resolution of their back pain. This is not commonly the case. Patients were assigned to either disc prosthesis surgery or rehabilitation. At 3 months, the results were similar. However, after 2 years follow-up, those with the surgery continued to improve while those managed conservatively on average had their pain return and mobility decrease. There is no indication, though, whether the patients continued to exercise after the initial management period. Also, facet arthropathy appeared or increased in 20 patients who underwent surgery versus 2 patients who were rehabilitated. In other words, no advantage to disc replacement and possibly an increased risk of facet involvement. Finally, let's look at a concern about traditional surgery, lack of proper annular repair. The title, Prospective Multi-Center Randomized Controlled Study of Annular Repair in Lumbar Discectomy, 2-year follow-up, published in Spine in 2013. Reherniation rates following standard discectomy range from 10 to 15%. Without a viable option for repair after discectomy, an open annular defect potentially allows for reherniation with resulting recurrent symptoms and the need for further surgery. Despite a trend toward higher reherniation rates, patients undergoing limited discectomy experience better clinical outcomes and higher overall satisfaction. The current practice is to remove as much disc material as possible to prevent reherniation. There is fear, though, that this will accelerate disc height loss and lead to greater end plate degeneration, resulting in worsened clinical outcomes and long-term back pain. Enter the Xclose tissue repair system. Basically, these are tension bands held in place with tissue anchors. Bands are comprised of a non-absorbable suture loop attached to two tissue anchors. Measured at baseline and at 2 weeks, 6 months, 1 year, and 2-year post-operative visits were a 10-point visual analog scale used to assess leg pain and back pain, and the Oswestry Disability Index in SF-12 used to assess overall patient functional outcome. This study was conducted at 34 U.S. sites with 58 orthopedic and neurosurgeons participating from March 2007 through November 2011. There were 887 patients recruited. 85% were deemed appropriate for annular repair with Xclose. For the Oswestry Disability Index scores, both groups had a baseline of about 58 points and a 2-year follow-up of 20 points. For the SF-12 physical component summary, both groups had a baseline score of about 29 points and a 2-year score of about 46 points. Therefore, no difference was noted between the two groups at any of the follow-up time points. Reherniation was statistically significantly lower in the Xclose group at both 3-month follow-up and 6-month follow-up. Surgical revision rates due to reherniation were lower in the Xclose group versus the control group. However, this difference was not statistically significant. Early annular repair methods required expansion of the laminotomy and increased procedure times up to 1 hour. Xclose was developed through the same laminotomy site, and annular repair was accomplished in less than 5 minutes in most cases and in less than 15 minutes in nearly all cases. The summary: surgery does not always accomplish the desired goal. Failure rates for new surgeries can be high. Although the intention of new procedures is to prevent the long-term consequences of older techniques, the literature to date seems to indicate no significant improvement overall in clinical outcomes or long-term degeneration. Probably the most important positive advancements are the decreased time for surgery, the decreased time for recovery, and earlier return to work. The lesson learned is not to assume that new is better, and also that more rigorous studies need to be performed on limited number of patients prior to the widespread adoption of a new surgical approach.